My name's Nicole Gadir. I'm the Executive Director for the Brain Injury Association of Massachusetts. Peggy and I connected at the SEED Summit more recently for one of the NASHA conferences, and she mentioned about the Medicaid administrative claiming and if I knew anything about it, and I said no, and she mentioned this could be a great opportunity for like-minded organizations. So I think from here we can kind of kick off, Peggy, in terms of the presentation for today. So.
Yeah, well, thank you. Thank you for partnering with us on this, Nicole. I'm going to actually bounce it over to Steve and his crew from HCBS to talk about Medicaid administrative claiming. They've taught me a lot about this along the way, and we have been very blessed to get some funding thanks to the help of Steve and Andrew and the work that they're doing. So Steve, I'll hand it over to you.
Okay, welcome. So I'm Steve Letsky. Andrew Selinsky works with me. We also are going to have Ami Patel on the call from the Administration for Community Living. We know Ami well. We worked with her when she was working for the state of Maryland, and we did some of the earlier Medicaid administrative claiming work, and she has been a great advocate for states and other entities that are working on Medicaid administrative claiming nationwide. And then we're going to have Peggy that we're going to have her do some of the slides too. So Andrew, if we can go to the next slide, I'll hand it over to Ami at this point.
Great. Hi, everyone. My name is Ami Patel. So I work within the Office of Network Advancement at the Administration for Community Living. And as Steve mentioned, I have been working on no-RUM-DOOR Medicaid claiming related work for a couple of years now. Prior to this, I worked at the Maryland Department of Aging, so I have state level experience and worked with Steve and his team for a couple of years there too. So just great to be on this call together, and thank you so much for the invite. I want to first here talk about sort of defining no-RUM-DOOR. So this is a vision, and the premise is about systems change, right? It leverages existing infrastructure to provide a coordinated way for people to access services in the community. So it's really about a network of community-based organizations, state agencies working to increase access to long-term services and supports for all populations. So older adults, people with disabilities, veterans, caregivers, anyone seeking access to services and maintain community living. And the vision started as a collaboration with the Administration for Community Living and the Centers for Medicare and Medicaid Services. And it's really defined by 4 key functions. So the first is state governance and administration. So this is ensuring there's a collaborative effort among multiple state agencies to understand the importance of access to services and coordinating that access. The second function is public outreach and coordination. So doing education, public awareness about services, ensuring there are key referral sources across the state. And then person-centered counseling is the approach for ensuring an individual can participate in informed decision-making about their needs and preferences. So state no-RUM-DOOR systems include a process to support the workforce by providing person-centered training, ensuring that that's an option for people as they look for services. And then lastly, streamline eligibility. So it's a way of coordinating all of the formal assessments and eligibility requirements into one process where individuals can truly tell their story once. So this is just the idea behind no-RUM-DOOR systems. In many states, you know, they have no-RUM-DOOR systems in varying levels. And so next slide, wanted to kind of demonstrate the connection points to state Medicaid and why the no-RUM-DOOR system plays a huge role within that, right? So each of these elements are key components to a state no-RUM-DOOR infrastructure. And I just want to emphasize again that states create their own no-RUM-DOOR vision based on structure, populations, or available resources. And there might be different levels of maturity and capacity, but each of these components are things that are happening at the state and local level and sort of help build those partnerships. So here specifically, trying to point out the various Medicaid related work that happens across all of the community-based organizations. So even councils, programs, So not just ADRCs or Centers for Independent Living, but USEDS, Assistive Technology Act programs, brain injury organizations. There's something here that speaks to sort of the Medicaid component of the day-to-day work that happens at the local level within those organizations. So we're talking about, Medicaid being a part of governance, local level services, including Medicaid outreach, application assistance, shared data systems, waiver service coordination, and so on. So in order to understand Medicaid administrative claiming, which we're here to talk about, it's important to recognize that all of this Medicaid related work is already happening across the states and within several organizations. So next slide sort of goes into that point of there being several foundational partners, right? So Medicaid is that foundational partner for No Wrong Door and just broader access systems. So with all of these community-based organizations and local partners, they make up the state access system, and it goes beyond just the organizations listed here. So again, thinking about the services offered within these organizations, the application assistance, person-centered counseling, care coordination, all of that is to provide, the holistic health, support the holistic health and needs of an individual in a coordinated way. And all of those activities can be sustained through Medicaid claiming. So you may be wondering, whether or not brain injury organizations across the country have connections to No Wrong Door system efforts, and many of them do, but we're happy to help kind of make those connections to ensure that you have the right state contacts who may already be working with Medicaid, have already built that partnership with Medicaid to, again, sort of take advantage of claiming, as you'll learn throughout the presentation. But this next slide is my last slide here, just pointing out that CMS has put out official guidance on Medicaid claiming for No Wrong Door, and it goes into several opportunities that states and local organizations can take advantage of. So including the Brain Injury Network, there's a potential to leverage existing claiming infrastructure within the state. And because of this guidance and the fact that CMS has recognized the role of No Wrong Door, we already have a lot of claiming happening across the country. 16 states are currently claiming, 12 more are in the planning stages. So again, there's definitely an opportunity to leverage that. And as I mentioned, we can make those connections to state contacts as you learn more. But yeah, I think now we can kind of turn it to Steve or Andrew to kind of go into exactly what claiming is and how it works.
Okay, so we're with a company called HCBS Strategies. The HCBS stands for Home and Community-Based Services. We exclusively focus on helping states and other entities to build up the HCBS delivery systems infrastructure. We are a mission-driven company. I founded this company based on the ability to kind of change the system. When I was 20 years old, I was volunteering in a nursing home and was really appalled by what I saw and wanted to change the system. So some of my early work was involved in the ADRCs and the development of that. And I really recognized early on that the funding was going to be an important component of it, and that the Medicaid administrative claiming was likely to be the most likely way to get some of that funding to the states and to the entities that are doing the actual delivery of the services. So currently we're working with Alaska, Alabama, Colorado, Hawaii, Nebraska, and Rhode Island. And we've worked with a variety of other states on administrative claiming and helping the states to build up the infrastructure for administrative claiming. So we can go to the next slide. Okay, so I mean, what MAC or Medicaid administrative claiming is providing typically a 50-50 match for activities that contribute to the efficient and effective administration of the Medicaid program. So that's the key underlying phrase, that what you're doing is making the Medicaid program more efficient and effective. So there's a lot of room for interpretation about what does make the program more effective. And I'm going to talk a little bit more about how that we have interpreted that for other states to kind of expand the role of organizations that are assisting people that are kind of in the pre-Medicaid phases within it. Now, the information referral activities and that service coordination is some of the things that are potentially matchable. Now, when you're matching it, you can't match any federal dollars. That's like a key component. You have to have dollars that are available for the match. So state-only dollars can count. Private foundation dollars can count, and other non-federal funds can be used. The one major exception to that is if you have like a private foundation that is funded by a service provider that's receiving a lot of Medicaid funds, that's where it becomes really fuzzy, and we might want to avoid that just because it can be perceived as the federal monies are being pumped back in to get match again. But if you're doing your own private fundraising for your Brain Injury Association, or you're applying for a separate grant from another entity on it, those funds potentially could be matched. And MAC is sustainable. It's not something that ends. It's something that's going to be ongoing as long as the Medicaid program is ongoing. So go on to the next slide. Okay, so now for the MAC funding, it can fund a large portion of the cost. And when we've been doing this with other entities, we've generally been finding that once you build up the infrastructure and do the training and kind of maximize how much you can be doing the max, that about 3/4 of the time can be considered Medicaid claimable. So when you get a 50-50 match, so like in Wisconsin, they had 76% and they got a match that covered 38% of their operating costs. So it's great in terms of securing state and local funding. In the work that we've been doing with Nebraska, that some of the entities have been using this to apply for other grants. It kind of helps to make the case for it, that they can make the dollars go further and gives them a competitive edge when they are applying for funding. And you're not necessarily needing to do any additional work for this. You need to have the way of documenting your time and so forth for it. But it's not necessarily requiring that you make any major changes to your operations to be able to achieve these dollars. Okay, the types of activities that are claimable under MAC are outreach and enrollment, information referral, case management, provider monitoring, planning and development, network development, auditing, and quality improvement. For you guys, you're probably doing a lot of the outreach and enrollment, the information referral components of it. You're probably doing some light case management, sometimes called service coordination, where there might be somebody that you're providing some initial information and referral and then kind of following up with them for a period of time until they become Medicaid eligible. Those are likely to be the biggest buckets that you're pulling from. An important innovation that we first did with Maryland was by identifying people that are likely to become Medicaid eligible because they're likely to spend down for it, because they're likely to go into an institution. So they're at risk of institutionalization and hence risk of spending down to Medicaid. That time that you're spending helping those people remain in the community should be considered Medicaid related, because you're saving the Medicaid program dollars. And we're finding that that's happening in many of the cases, that you're working with somebody that's taking 6 months to get them on a Medicaid waiver, and the time that you're spending working with them is keeping them in the community, preventing them from going into a nursing home, preventing more adverse events that are happening to them, and hence that they would be more costly when they actually did come onto Medicaid. So that becomes a key component, because there's some of the people that you're working with that are Medicaid eligible, but I'm guessing that a lot of the people, especially the people that take up a lot of your time, are the people that haven't gotten onto the Medicaid waiver yet, that you are you're receiving a call from them and spending some time with them, helping them to navigate the system and so forth, and that the bulk of the time for those individuals could be eligible, could be Medicaid eligible. We're finding that it's about 80% of the people, 80 to 90% of the people that are actually meeting that criteria. And for the financial component of it, with older adults and with adults in general, we look at the cost of a 6-month private pay in a nursing facility kind of sets that threshold. So if their income and assets would be exhausted with a 6-month stay at a private paid nursing home, then they would be considered at risk of spend down, and that's the threshold that you would have for that. And that does likely cover the majority of the people that you were probably serving. Okay, so we can go on to the slides and go on to slide 13. So we started working with Nebraska in 2016, and we did some evaluation work. So their program, they're like most states, their Aging and Disability Center, Resource Center started out through their area agencies on aging. And Nebraska, it was pretty much solely their ADRCs. They had the mission of having these disability partner organizations that would be playing supporting roles to other populations. But preliminarily, early on, they were playing very small roles. And when the state allocated funds to the AAAs and to the disability partners, the disability partners got a very small amount of that budget. So we're getting like, $8,000. I think the Brain Injury Association, that was what was allocated to them. But in Nebraska, the disability partners are the Monroe Meyer Institute, which is the University Center on Excellence on Developmental Disabilities, Brain Injury Alliance of Nebraska, Easter Seals, and the League of Human Dignity, which is a center on independent living. So we can go on to the next slide. So as I was mentioning, the challenge was all of the disability partners were asking, about their role within it. They were kind of saying like the ADRC felt like the D was just a little d in the ADRC, and that they weren't having a major role. And if you looked at the numbers and the dollars that were coming in, the people being served, that the disability partners were really an afterthought and weren't well integrated. So next slide, please. So the Medicaid administrative claiming helped to really change that. While there's still not that much state dollars that are allocated on the ADRC side towards the disability partners, they're able to really maximize this by matching other funds and other existing funds that they have. So they are providing that information and assistance, the options counseling and the short-term case management, and that they're drawing down the MAC through that. And that's allowing them to be more full-blown partners. And it's primarily just because they have a vast, most of their funding is non-federal funding, and other state funding or funds that they've raised, and they're able to draw down the match on that. So Andrew, we can go to the next slide. Okay, so this expanded definition that was talking about of MAC has become the primary funding source for the disability partners, that they're serving mostly low-income at-risk populations who are not yet enrolled in Medicaid, and that they're using that private funding, fundraising, and the grants from foundations. And as I mentioned, it's offering that competitive edge when they're applying for new grants, that they can be matching these funds when they are submitting an application. So in terms of what we've been managing to receive, Nebraska as a state in 2021 received $2.2 million, and the funding has been increasing quite substantially on it. The percentage of time that's Medicaid related started at 55.2%. But with working with them with training and other program enhancements, it had risen up into about 73%. Of the $2.2 million, that about 1.6, almost 1.7 went to the 8 AAAs, and 365,000 went to the 4 disability partners, and 230,000 to this SUA. But these numbers have actually changed quite a bit in 2022. Where we're seeing that the numbers have been enhanced quite substantially. So like we're seeing like in the Brain Injury Association for that, in their first quarter, they only included 2 staff members, and their first quarter claim, they received just about $26,000 in match that was eligible for it. In the latest quarter, they've increased that up to that they're nearly at $80,000. Per quarter. So that's, well over 240, they're approaching like $250,000 per year on this for it. Actually, and you get the number annualized on it. I was trying to do the math in my head. So it's like $315,000 annualized in terms of funding that they're going to be able to draw down on each year. And this has allowed them to have a lot more flexibility and to kind of reinvest the money in their programs and serve more people through MAC. So I'm going to hand this over to Peggy now for talking about how this has worked within their organization.
So it sounds like we're rich. Well, we're getting richer thanks to MAC dollars, but I was one of those, when Steve and Andrew first said, Peggy, you got to do this, I kept thinking, they're calling the wrong person. We don't bill for Medicaid. We're not a Medicaid provider. I think I avoided them. I don't know. These guys would know how long I avoided them, but longer than I should have. So when I finally listened to what they had to say, it's like, I just groaned like, oh my goodness, how much work is this going to be? Only to find out that it's not that much work. But a lot of you as brain injury community, you know our mission. As you can see from some of the information Steve has already shared, that we're one of the smaller disability partners out of it. We are 8 members or 8 staff members. So we weren't really sure how much we were going to get from this. We as an organization don't receive a lot of federal dollars. A lot of our work is certainly private foundations. We are getting some state dollars. In my budget, I'd say roughly about 60,000 is actual federal dollars as of right now. And so a lot of the funds that we were able to pull down are able to be matched. So, and we do have resource facilitation here in our state. So I have 5 full-time resource facilitators at this point in time. Our resource facilitation program is information referral and options counseling and case management. So a lot of what we're doing is stuff via the phone. We are meeting some people in the home and in their communities, but for the most part, given the size of our state, a lot of it is through the telephone. So Andrew, if you do the next slide. So as I mentioned, I avoided them for a while because we don't bill Medicaid. And when they sat down and told me what I was going to need to do, they talked about these time studies. And I'm like, oh my goodness, I think we've all encountered time studies before. And it's like, how much of a headache is this going to be? It really sounded scary. It's like time studies twice a day. I'm like, oh my goodness, really? It really ends up not being that bad. I think at this point, all of our staff can get those 2 time studies done in probably less than 30 seconds. It does not take a lot of time, and they have it set up so that it's just a matter of click, 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 and we're getting it done. Another component, which I should have looked ahead. I think, Andrew, you can maybe talk a little bit about the cost pools spreadsheets. I too thought, oh my goodness, what's this going to entail? It really wasn't that bad. Well, it was bad to begin with, but once we figured out how to do it, it's not so bad. I can remember the first time we filled out this cost pool spreadsheet, my the gal that helped me with it, which is my treasurer, we both kind of scratching our head like, gosh, if we get $300 out of this, will it have been worth it? And she's like, well, maybe if we get $1,000, it'll be worth it. Anyway, so I think our first check was, I don't know, close to 25,000 or something like that. And we just both, our jaws dropped like, oh my goodness, I had no idea we would be making that type of money. So it felt like a lot of work to start with, but again, thanks to Andrew and Steve, they held our hands and helped us walk it through. So that MAC experience initially was kind of scary, but ended up being very fruitful. Really for us, as the slide shows, it's been really life-changing. These funds have given us the ability to really reinvest in our staff, reinvest in some work that we've been wanting to do with our data, capturing through data through Salesforce and whatnot. So they've been very, Steve and Andrew have been very helpful, and all the rest of their staff and coaching us through that. The other things that we're doing with some of our extra funds that we had not anticipated was it helps with our rising transportation costs. We've been able to reinvest that into doing some more marketing and outreach. It's helped us with our strategic planning. And at this point, as we are doing our strategic planning, some of the conversations we're having is, anticipating what MAC dollars that we are going to be getting. How can we reinvest that into adding more staff and really looking at where are there holes in, and where are we needing more assistance with our staffing? So next slide. I put together just and I have this slide on here, but I feel like a lot of us already kind of know what resource facilitation is, but this was just a quick case study of the type of client that we we get frequently. This gal came from Colorado, moved to Nebraska. She was pretty much on her own. Her mom had contacted us and said that, her daughter was needing some help. So one of our resource facilitators had been working with her. And an example of things that we were giving her help with, or there was many concerns for her safety, but she was, for example, not taking her medications as prescribed. Her reasoning and understanding because of post-injury deficits were poor. Her balance was poor. She reported falling frequently. She complained of headaches, migraines, anxiety, depression. She had a history of eating disorder and was bipolar, had suicidal ideations, but no suicide plan. So next slide, our resource facilitator went in and worked with her, and typical of most of you and your staff do is with resource facilitation, we helped her and her sister complete the Medicaid application and applied for our age and disabled waiver, helped set her up with some outpatient therapy, also got her connected with the YMCA. We helped her mental health professional. There's a lot of our mental health professionals, is probably typical in your state too, don't necessarily have experience with brain injury. So we did our best to kind of get that person up to speed and understanding a little bit more about brain injury. We also helped her set up some goals to alleviate isolation, gave her some volunteer possibilities, got her again set up with her bill pay system, and also assisted her with some medication management. So all of those things kind of led into, well, by providing that right amount of support in the community, we can hopefully help keep her out of the institution. So that's kind of my quick summary. Andrew, next slide. I think that was it for me. So.
Yep, thanks, Peggy. Okay, so now we're going to touch base just on how implementing MAC may work in your state. And so one of the big things before we even jump into anything that I just wanted to touch on is that we've done presentations for brain injury networks previously. We've also done presentations for Easter Seals on a national level. So one of the key things as you're kind of considering and we're talking through these slides is, what is your state doing right now? So if you have connections with your ADRC in your state, the ADRC network in your state, or if you have connections with the entity who's overseeing Medicaid administrative claiming at the state level, or you have connections within the state Medicaid office, those are really good sources to just kind of see what's going on. That's kind of the biggest thing, is if there's, brain injury in Nebraska was able to join up with the existing Medicaid administrative claiming effort. So there was already kind of that groundswell and that momentum that was going. So one of the big things, and I'll repeat this again as we walk through, but just check in with members from your state who are potentially participating in a no wrong door effort or Medicaid administrative claiming already, to kind of get a feel for where things are at. But what happens after the fact? So you must be working with your single state Medicaid agency for Medicaid administrative claiming. So in Nebraska, brain injury was joining on to that effort that was going through the ADRCs already. And then that was overseen by the State Union on Aging that oversees the area agencies on aging. And then they were able to make the connection with the state Medicaid agency. And then the state Medicaid agency has the relationship with CMS at the federal level. So you have to be able to connect to an existing, to set up to your single state Medicaid agency at the very least. But also it's helpful to connect, if MAC is already occurring in your state, to connect with those entities where that infrastructure has already been developed. You may be able to pursue it. If you're not a governmental entity, it may be possible to use an administrative contract. but it'll depend on how the infrastructure in your state is set up. It would likely be if you're joining up with other agencies that are already claiming MAC, you'd probably be using a similar infrastructure, but it would just kind of depend. So that's again where it's important to make that connection in your state and just get up to speed with what's going on. We can help answer questions and we can help join in conversations, but really what you guys need to be able to do is figure out where your state's at in the process. So the requirements for MAC through an administrative contract. So if it is the administrative contract route, have to follow those procurement regulations, have to have a designated mechanism for activities or time that's Medicaid related. So in Nebraska, we do this through a time study, but if you go through an administrative contract, it's a bit of a different process. But then that you have to be able to attach costs to those activities in either mechanism. So that way if you're doing a time study and you're saying we're spending this much time on INR, well, there's a cost associated with providing that time. And so you have to be able to document both the time that you're spending on those Medicaid related activities and also the costs associated with those activities. And so in Nebraska, what this has been, we've folded this into the Public Administration Cost Allocation Plan in coordination with the Medicaid agency. So their MAC approach is all spelled out within that POCAP. And so it would likely be in your state that is if it's existing infrastructure that has been spelled out. If not, then it might be working with your state Medicaid agency to kind of see what needs to occur for this to happen. So for the random moment in time study, so if you don't go the administrative contract route, you are potentially a governmental agency, or you're joining onto an existing MAC effort that does do that time study and those costs pools. So because this is the case, then we need to be able to have, if there's governmental funds involved, we need to be able to have a way to really show this is the time that you're spending on Medicaid related activities, and these are the costs associated with those, because it really goes back to intergovernmental transfers, making sure that those funds are being allocated appropriately and they're being reimbursed appropriately. So if your agency is part of or owned by a governmental agency, or you're joining an existing MAC effort where there's governmental agencies involved, then that might mean that you're going to have to do this time study and this cost pool that Peggy kind of introduced that concept. We'll talk about it a little bit more. But if your state already has that infrastructure developed, it's likely just some adaptations for you to join on to that. That's what we found in Nebraska, but it just varies state by state because each state has their Medicaid program set up a little bit differently. And then the differences in those Medicaid programs also means there's a bit of a difference in MAC across the states and no wrong door across the states as well. So that claiming infrastructure, and I'll give some examples of what we're going through in Nebraska. We've also done similar things in Hawaii and in Maryland. But we have to be able to establish the cost for staff time. We have to be able to document that Medicaid related time. So I'm just going to keep kind of plugging on this because you need to be able to say, this is the percentage of time we're spending on supporting people in Medicaid related activities. And this is the cost that's associated with it. So each quarter in Nebraska, we summarize all of those time studies that the agencies complete. And we say, this is the percent of the time from those time studies. So all the agencies have to do is they have to go in and complete that time study. We do all the other work with that. Then they also have to submit a quarterly cost pool. And then that cost pool, that's just documenting staff costs. So salaries, benefits, and then other agency related expenditures at the staff level. And so with those two things, we're able to say, this is the cost, this is how much time they're spending on Medicaid, and we put those together and we can get that claim back. But then there's also that other layer of those agreements and approvals. So the process does need to be agreed upon by the state Medicaid agency. There has to be approval from CMS of the overall claiming methodology. And then there also, if you're joining an existing effort, then you'll need to coordinate with the agencies, whether that's your state union on aging or another entity that's overseeing the MAC claiming effort. You'll need to have some sort of agreement with them. So that way those funds can flow back to you as well. So the way that it works in Nebraska, in several other states that we've worked with, is that we're gonna add participants to the cost pool. So we're gonna say these are the folks that are participating in the time study. Then we run the time study to see how much of their time they're spending on Medicaid related activities. And then, like I said, we're getting quarterly spreadsheets. And so our team, we aggregate all of this information. We oversee the time study. We provide training. So we kind of just help coordinate what's going on with MAC and make sure everything's working properly throughout the state of Nebraska. And that's our role within that. So that way, if they have questions, if any of the agencies have questions, they just come to us. And we have a contract with the State Union on Aging to perform those services. So we get those quarterly spreadsheets, then we calculate the percentage of Medicaid and percentage of Medicaid related time. We submit that to the State Union on Aging. The State Union on Aging says, okay, they take a look, they ask us any questions, they submit that to state Medicaid. And then state Medicaid, as part of their regular request for funds from CMS, they'll submit that. And then those funds are brought back to the state Medicaid agency. And then that's where those agreements and approvals come into play, is how those funds flow back down to the local agencies. Right now, under the updated methodology, Brain Injury Alliance will have a direct contract with the State Union on Aging. So that way those funds just come right back to them. And the State Union on Aging has said, you guys can have all the flexibility that you want with these funds. You're able to spend them how you want. Of course, that does make more sense to reinvest them in those programs that where you have some overlap with the MAC related activities. But however you want to, that's what Nebraska has said. Other states may put some stipulations on how those funds can be spent. It just varies state by state. So for documenting Medicaid related time, this is what we're doing in the cost pool. Or excuse me, this is what we're doing through the time study. So in the time study, we're saying you're performing INR, you're performing case management, you're doing some benefits assistance or application assistance. Was that activity Medicaid related or not? So the first layer is figuring out, were you doing INR, were you doing case management? The second layer is, was that a Medicaid related activity? And there's also a bucket called general administration, which is, those are neutral tasks. So time you're spending, on leave, on break, updating payroll. There's some things that are going to fall outside of Medicaid versus non-Medicaid tasks. That's what we're talking about in that neutral bucket of general administration. But in general, what we're looking for is, was the task Medicaid related or not? The codes. So if you're using codes like INR, information referral, or INR, case management, benefits assistance, those are things that are used in other states that CMS has seen before, they're comfortable with. But as you kind of look at other tasks that you may be performing, if they don't fall within one of those, that's where it's going to be important to work with your state Medicaid agency to kind of figure out, does this fall within the eligible activities for receiving reimbursement? And that's what we've had to do with each of the ADRC partner organizations in Nebraska, is say, okay, tell us a little bit more about the functions you play within the system, and then where they might fall within the existing infrastructure. So I kind of talked about this at a higher level, but establishing the cost time. So in Nebraska, we have a standardized quarterly spreadsheet where they say this staff one was participating in the time study this last quarter. This is how much their quarterly benefits, their quarterly salary, and other related expenditures. So for those approvals, if your state's currently claiming for MAC, they should have cost categories already that they're utilizing. If your state is looking to start a MAC process, then the cost category should align with the Office of Management and Budget's guidance, and also your state practices. When we were getting this off the ground in Hawaii has they have well-defined cost categories where they said, for personnel costs, this is what we're considering. And that's what CMS is really looking for, is definitions for each of those cost categories, so that way that they're comfortable with the costs that you're reporting. And also the mechanisms for reporting costs, it might vary in your state versus what we're talking about in Nebraska. But as a basic element, you need to be able to report those costs that are associated with staff either participating in the time study or as part of that administrative contract. So I talked also already about the likely chain of agreements and approvals, but CMS, the Centers for Medicare and Medicaid Services at the federal level, they need to have a relationship, a contractual relationship with your Medicaid agency, your state Medicaid agency. There needs to be an agreement between those two entities as to how they'll be receiving that reimbursement and what the reimbursement is going to be for. So CMS does play a role in the approval process of Medicaid administrative claiming for your state. And then that Medicaid agency, they have, there's a contractual relationship. If it's a different agency that acts as the operating agency, that oversee the state agency that oversees, your no wrong door infrastructure, then there needs to be an agreement and a relationship between those two, because the funds are going to flow from that Medicaid agency down to that operating agency. And in Nebraska, there's the state Medicaid agency, and then there's the state Unit on Aging, and those are the two that have the agreement. The State Unit on Aging then oversees the ADRC partner organizations, and they also oversee the area agencies on aging, the other local sites that oversee the Aging Disability Resource Centers. So that chain of operations and that fund flow is really going to be defined through these agreements. And so it's a really critical part of the process if your state is looking to kind of bring MAC into the state, that if it's not already occurred. If you're joining on to an existing MAC effort, these agreements are likely in place, and it'll likely be your role will likely be in these latter two boxes of how you're going to be connecting with the operating agency and how those funds will make it to you. These the methodology and the agreements and how this all works is going to be summarized in that cost allocation plan, the public assistance cost allocation plan. And then CMS will be approving the amended plan as part of that. And so that's just where CMS has the opportunity to review the methodology, ask questions, make sure that everything that your state's proposing is on the up and up. So as far as the state unit responsibilities, run time studies, gather cost spreadsheets, ensure that the appropriate staff are participating in time studies, provide quarterly invoices to Medicaid for reimbursement, disperse those reimbursements to the local agencies, and then have the quality oversight and compliance. Now, Steve and I, our team, we are primarily operating this on behalf of the State Unit on Aging. We have a contract with the State Unit on Aging in Nebraska, where we perform these activities on their behalf, and then they're overseeing our contract, making sure that we're doing our due diligence and performing these tasks appropriately. One of the big areas that we've kind of taken up is the quality assurance and compliance. Each month, there's at least a 5% review of the cases for each agency. They go back in and they just verify if somebody reported that they were performing INR and they said it was Medicaid considered, they have provided a description of the activity. And are all of those things lining up? If your staff is not a case management staff, but they keep reporting that they're performing case management, raises some red flags. And so that 5% review just helps us make sure that there's that ongoing quality. But we also offer regular trainings and ad hoc trainings for the agencies involved. And we coordinate with the fiscal teams each quarter to get those cost spreadsheets in and ask any questions if we see any issues. For local agencies, so the area agencies on aging, the ADRCs, the partner organizations, the responsibilities is that your staff are performing reimbursable activities. Those staff are participating in the time study. So we want to make sure, in order to maximize the amount available for reimbursement, we want to make sure that all those staff performing those activities are included within the time study. So that way we can also include them in the cost side of things, in the cost pool. And then just making sure that staff are attending trainings, that they're comfortable and familiar with the methodology. And then you're submitting those timely fiscal spreadsheets. In Nebraska, that's on a quarterly basis. That's generally what we see. Some states may require monthly or more frequently, though. So that's kind of that is the summary of our presentation. But again, just like I said at the beginning, I would encourage you to first if you're not familiar with Medicaid administrative claiming and you have somebody at the Aging Disability Resource Center, you have somebody at their state Medicaid agency, or you have somebody within the state that is working on a no wrong door effort, that would be a good place to start, because we can help move forward some conversations. If you give us an idea of where your state is at, we can help you brainstorm. But because each state is at a different point in their process, it's not something where we can blanket statement say, yes, this is absolutely what your next step is. If you're able to join an existing effort, that's great. If your state is interested in MAC, and they want to know how to go about doing that, it's a different conversation. And so we're happy to provide any sort of support that we can with that. Steve and I are always happy to hop on a call and answer any questions, but you know, in the role that we play in Nebraska, we do have a contractual relationship, but just for those kind of getting the system up and running, as Steve mentioned, we're a mission-driven company. It's something that we would be happy to just join on a call to answer questions and continue that conversation forward.
Yeah, and it has been or is working out in some other states. For in Colorado, we actually have the Brain Injury Association and Easter Seals are both interested, and I was just following up on an email with the Colorado with the state to see about including them in an existing time study.
And there was a question in the chat of how the company is funded. So within Nebraska for our efforts, we have a contract with the State Union on Aging to perform that. It was through an RFP process. And so we bid on that process. We have extensive experience with other states in overseeing Medicaid administrative claiming. So that it is a state procurement contract that we have with Nebraska.
Yeah, but the other work that we've been doing, just like these calls and just trying to see if we can help light a spark in other areas, that's all been pro bono. That's not been work that we have been having contracts on. It's consistent with the mission of the company. So that's why we do it. And we have plenty of work. So we're really not trying to sell you on these contracts.
I think we'll open it up for any other questions. I appreciate those that have been putting questions in the chat, but any other questions for us at this point?
I've got a question. This is Lee from Mississippi. If you're not doing resource facilitation, but you're doing INR, how much value is here for us to try to go forward with this?
Well, I would suspect with the vast majority of the people that you're doing INR with are going to be at risk and fall into that category, that they can be relatively low income. In addition, one of the other things that you're considering when you're doing INR is if you are considering Medicaid as a component of it. So if you're doing the INR and as that part of that conversation that you're thinking about whether or not you should be helping the person to explore Medicaid and to access those Medicaid services, then it's Medicaid related. And that's probably going to cover a lot of the INR that you're providing.
And that doesn't mean that the person ultimately has to go the Medicaid route. It's more of you're having a conversation with them to understand their options to make sure that if Medicaid is the best route for them to go, they would go that route. But it's making the Medicaid system more efficient and effective by either helping somebody go that route or diverting them from going that route too.
Yeah.
And I would say here in Nebraska, I mean, the majority of the work that we're doing with clients is INR. There's certainly a component of it that's case management, but for the most part, the bulk of it is INR. And we're able to put that towards it.
Have any states run into that? I know there are many states across the country, their information and resources, they're getting contracts for their INR. So are there ever any concerns about double billing or, you know, utilization of time? And, you know, I don't know if you guys could talk about that at all, just for people to be thinking, you know, if your salary, your time is actually being paid for on one contract versus another. I just, you know, because some state agencies do pick up for a lot of the brain injury associations and alliances to be answering their phone calls. So I just wanted to throw that out there. So
yeah, and in some cases, like if the state is making a contribution to the Brain Injury Association, then this should be framed as, and it's state-only dollars that they're using that for. This should be framed as the opportunity to make those state-only dollars go further and to draw down the federal dollars to match that. So it could put you in a stronger position. You know, there's always going to be a concern about double dipping, but it seems like you're serving an unmet need, and that typically the population that you're providing the supports to is population that nobody else really has payments for, or necessarily has it in their mission to serve.
And I can speak for us here in Nebraska. So we have a brain injury trust fund, or that they've renamed it to Brain Injury Assistance Act. And those are straight Nebraska general fund dollars at about a tune of 450. And so that's how we were able to hire our 5 resource facilitators. But we were able to go back to that committee that assigns us those dollars and say, we're able to get about, a nearly 50% match on those dollars. So the dollars that you're giving us are going further. And again, none of those are federal dollars. Those are only state dollars. So that's how we're able to leverage that. I think there's just a small portion of our budget that we actually get some federal dollars. And so we just simply don't, that all gets pulled out, and we don't, when I go to do my time study, if I'm working on a project in which I'm getting some federal dollars for, and they have it set up, so I just click that button and it's like funded by another program, so it doesn't get thrown in the mix.
And Peggy, I know this group has the names of everybody that registered and that actually clicked the link today. I know there was a PowerPoint. Could we just make sure everybody on here gets the PowerPoint? I know there's a lot of information, a lot of resources. I'm sure everybody actually needs to read this and look at this, with a couple cups of coffee at some point, so.
A cup of coffee or a glass of wine, whichever makes your fit. Yeah, we'll certainly provide that.
Thank you so much, Peggy, for putting this together. I know a lot of the states across the country are supporting brain injury survivors in some form or another. And I know some states are utilizing different funding streams. So it's always great to learn about new funding streams,
And this,
Margo was asking about provider monitoring. That's typically that if you have a network of providers and you're overseeing, making sure that they're providing the services that were contractor authorized or something like that. That's typically not something that we're going to see a brain injury association doing.
and I think for all of you, I mean, as you participate in this, and I really wanted just to bring this to our brain injury community, just because I was a doubter, I was a naysayer, and it's like, oh my gosh, it really is the pot of gold. And if we wouldn't have been given this opportunity, I wouldn't have gone out looking. And I see how it has changed the trajectory of the work that we're doing here in Nebraska. And even if just one other state gets as lucky as we did with finding that magical pot, I think it'll move brain injury forward in your state. And to me, that means we're moving it forward for all of us. So I do hope some of you, it sparked enough interest that you go, I wonder if it could be us. It might not be for all of you. You might not have the mechanisms in place. And for that, I'm sorry. But if it works for you, it's been great.
And if you're interested, then you can shoot us an email. The way it's happened with the other states that we've been connecting them on it is that they've shot us an email. We've kind of had a discussion about what they're looking for on it. And then we've connected with Ami to see if she knows in terms of what's going on within the state, and if there's a likely fit on that. That gives us a quick assessment about how feasible this is and what are the potential obstacles on that. And that'll give you information about whether or not it makes sense for you to pursue it.
Yeah. And I also know that there's just, and if somebody's, Nicole, you got to run, but for some of you that I know Alliance states, you might just have a board. You don't really have staff on board. But even we are a small state. I guess when we started this whole process, we were a staff of 3. And so I guess my encouragement is like, small even works. You don't have to have a staff of 15 or 20 or 75. Small works too. So it's helpful.
Thank you, Stephen. Thank you, Peggy, Andrew, and Ami for putting this together. We really appreciate it.
You're very welcome.
And I have
Thank
to get off. I have a board meeting to file our audit and our UFR, so which at times can be more complicated than Medicaid administrative claiming. So I think I'll end on that note. So.
Well, thank you all for joining us, and we will definitely send you the PowerPoint, and feel free to reach out and ask any of us questions along the way if you have them.
Great.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.